Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show, bringing you another really awesome guest today, involved in creating a better tomorrow for millions of people out there. Today, we have the honor of being joined by Dr. Ashwin Vasan, who is the Commissioner of the New York City Department of Health and Mental Hygiene. He is a primary care physician, an epidemiologist, a public health expert, has over two decades of experience working to improve physical and mental health, social welfare, as well as being involved with public policy for marginalized populations in the New York City area, as well as nationally and globally. And since 2014, he served on the faculty at Columbia, Mailman School of Public Health, and Vagelos College of Physicians and Surgeons, continues to see patients as a primary care internist. Dr. San most recently served as the president and chief executive officer of Fountain House, which is a national nonprofit voting to improve health, increase opportunity, and end social and economic isolation for people impacted by mental illnesses. And from 2016 to 2019, he served as the founding executive director of the Health Access Equity Unit at New York's Department of Health and Mental Hygiene, focusing on this really interesting intersection of clinical and social services for the care of people involved in the justice system, as well as other vulnerable populations. It's the first of kind government program of that type in the nation. Early in his career, spent nearly a decade at the intersection of global health, HIV research, primary care, working with partners in health in countries like Rwanda, Lesotho, as well as with the World Health Organization in Uganda and Geneva. Did his undergraduate degree in economics from the University of California, Los Angeles, master's in epidemiology, Harvard School of Public Health, medical degree from University of Michigan, and a PhD from the public health and London School of Hygiene and Tropical Medicine. A lot to get into today. Honored to have him with us. Dr. Ashwin Vasan, thank you so much for taking the time to come on the show today.
Thank you for having me, Ira. It's great to be here.
Great having you. Would love to start off and go right into sort of the background of this emerging journey you've been on. As mentioned in the bio, you started off your early career at Partners in Health. I saw you published quite a bit with the late Dr. Paul Farmer on all sorts of topics from HIV infections in Tanzania and studying antiviral therapy in Uganda to being involved with the Global Fund and procuring antiretroviral drugs. Love to hear about sort of the beginning of all this and how you got focused on so the picture of global health and social medicine.
Well, I appreciate it, and I love to be here, and it's nice to get to talk and to step back and kind of think about what got you here. Sometimes you're just so focused on the work ahead of you. This really goes back much further than that. I was inspired very much by my mother, who is a neonatologist, or was a practicing neonatologist in the South Side and West Side of Chicago, where I grew up. And took care of a lot of premature babies whose outcomes were very much impacted by their social circumstances. And as a child, I would shadow her to the hospital, and I got to see firsthand what it looked like to travel from my home of relative safety and privilege and into communities where that wasn't guaranteed. And to watch her treat everyone with dignity and compassion. And I was really inspired by her service. And just to say that, my entire childhood was really punctuated by those same families whose babies they saved they would keep in contact with her every single year. And during Christmas, our house was full of Christmas cards with pictures of these children growing up, children that wouldn't have necessarily been around were it not for my parents, children from all walks of life. So that was a pretty big person to have in your life and an exemplar. In fact, it was very intimidating on some level because I wasn't sure I could be a doctor. I wanted to be, and I thought I would pursue that. But I was pretty unsure of myself entering college, and so I actually studied economics.
Hmm.
And I'm so glad that I did because it gave me this much broader view of life and sort of much broader view of the choices we make in policy, in government, to affect entire societies and to affect the ways in which humanity grows and develops. And I was particularly taken with development economics in part because of my experiences going to India as a childhood and seeing just the vast inequities between my family's existence in India and my own in the US, and even within my family, seeing really differential outcomes. Now, you're a young person, you're not you're not really processing all of that in real time. But as I look back on it, it really left an imprint on me. So I studied economics, I studied development economics. I thought I was going to go into maybe like work for the World Bank or something like that, or aid to do international aid. And then I discovered public health my senior year of college. I started to take some classes in public health. I always had in the back of my mind I would go to med school, but I was really captivated by what I thought was a marrying of my two interests, which was these large scale social, economic, political, policy forces and how they can converge on the lives of people and groups of people and really affect health outcomes. And that brought to light a lot of what I saw in my own eyes, right? I saw those differentials in traveling just 15 miles from my home to the west and south sides of Chicago. I saw that jumping on a plane from Chicago all the way to South India and saw those differentials, family members with the same illnesses that my loved ones here have, but with very different outcomes due to access to care and the foundational economics and social system. So public health was for me. And then I pursued a public health degree first, but all the while kind of maintaining my ability to go to med school and pursue that if I wanted to. And as soon as I landed in Boston, I met Paul Farmer and was really captivated by his point of view, which was, yes, we want to change these large scale forces and rebalance the world toward and bend the arc of the world towards more justice and fairness. But your window into that ability to change is strengthened by your ability to be at the bedside.
Hmm.
And so that's when I really recaptivated my interest in going to med school. And he inspired me to go back and get into med school, which I did. But I also wanted to work for him, and them, him and his co-founder Jim Kim, who went on to lead the World Bank and Dartmouth and did other things. But at the time, he was leading the effort globally to scale up access to AIDS drugs. And this is the turn of the century when this was the singular public health issue of our day.
Right.
And for a young person entering the field, I was inspired to work on this issue. And the terms were very stark and the inequity very real. We had developed a treatment here in the global north, which was now saving lives,
Right.
triple combination HIV therapy in 1996, which was discovered, and it was now being used, but we couldn't get access in the developing world where the majority of cases, infections, and deaths were happening. Millions of people, entire societies ravaged by HIV, generations orphaned, economies destroyed. So this was an issue of basic fairness and morality for me and for them, and they certainly imparted that on me. But I wanted to work at scale, so I followed initially after working for Partners in Health as a intern, as a student. I followed Jim to Geneva to the
Right.
WHO to try to work on this bigger picture scale up of antiretroviral therapy. How do we take the principles that Partners in Health brought to light of treating people with this complex illness in some of the hardest places in the world, like Central Haiti and other places like Peru and otherwise, how do you take those principles and scale them
Right.
to large multilateral institutions like the WHO, the UN, just to governments, ministries of health all over the world. And so that was my focus. And that really got me into the nuts and bolts of how you build health systems, how you build public health programs, all the while attacking what I thought was the central challenge of our time, which was HIV.
Yeah.
And so that really was the focus of my work for the better part of a decade. Um, and then, came back to the US to train in internal medicine and primary care here
Hmm.
in New York, and found that in my real world practice, I was confronted with many of the same inequities and challenges that I had been working on for a
Sure.
decade. And, I was here as a resident during Hurricane Sandy, for instance, and I just saw how many people suffered and how many, people suffered differently based on their zip code, based on their race, based on their economic status and wealth, based on their language and access. And so realized over time that these same issues that I was working on for a decade, these inequities were playing out right in front of me,
Yeah.
and I could do something about it in my backyard. So after joining the faculty at Columbia, continuing to work on global health, I was really brought into the domestic public health fold by Mary Bassett, who was my predecessor. One of my predecessors here as Commissioner of Health, went on to be the state health commissioner of New York also, and said basically to me, she had a very similar career where she had worked globally on HIV and domestically here in New York, and said, look, everything you learned out there is applicable here. And so inspired me to come back to the health department, or to the health department, and to work in government and in public health. And I was just so inspired by that work. And it's kind of led me to where I am today, working domestically, really focused domestically, still able to build those bridges between what we're doing here in New York and what's happening globally on
Right.
so many fronts. But that really grounds me here. And I've been in New York for almost 15 years, I guess. So it's been a great journey, and such a um, privilege to work in public health, and not just now at this time in the pandemic and post-pandemic era, but just generally. I think working in public health, working in New York in public health is a real honor.
Hmm. Hmm. Yeah, I mean, you mentioned several things there. You talked about yeah, obviously you like to work on the big picture items, and a theme that comes up in a lot of your work. And I want to touch on a couple of these sort of ex-US programs that you were involved in. Is this theme of sort of these public health verticals that a lot of this stuff will never be solved by, as we used to say in the pharmaceutical industry, the single magic bullet. We really need to think broadly about social determinants of technology, of medicine, of everything that goes in that basket. And I think, an interesting place to start would be some of your work, actually, with your dissertation, where you're looking at this really interesting, in this case, the integrated management of adolescent and adult illness guidelines. So here you weren't focused at all on a specific disease, but specifically focused on actually primary care delivery processes in general, which in this particular case, because you were in Rwanda, looking at infectious disease, chronic degenerative diseases, all sorts of aspects of social determinants of tobacco use, alcohol use, physical activity. Say a little bit about what you learned, because I think this, and then we'll contrast that, say, with what you did later at WHO in terms of the Global Hearts program, where there you are focusing on a specific disease. But let's talk about that one first, 'cause I think it's kind of
Well,
important.
I'm so glad you're asking me this, because I don't think I've ever talked about my dissertation with anybody
There we go.
since I submitted it. So I'm very glad to do that. Look, I think that work was very much an outcropping of my work in HIV. So
Right.
if you think about it, right, we had this massive effort to get 3 million people on treatment by the end of 2005. When
Right.
when it was launched in
Yeah.
2003, 2002 Barcelona AIDS conference, but really 2003, we only had about 400,000 people on treatment. That was about, less than 30% of the need, like
Yeah.
20% of the need. And that was also only 50% of the need, right? So 3 million people was only an estimated half of what we thought was actually needed in terms of who needed treatment. Obviously, our understanding of that has shifted, right? We now put people on treatment early and often. We don't wait for CD4 counts. But remember, we were dealing with a relatively scarce resource at
Right.
the time. AIDS drugs weren't everywhere as they are today. So we wanted to mass distribute this medication. Mass distribution of anything, as we learned in COVID, requires the health workers to do it.
Right.
Health workers require a system in which to work so that they can do their work and deliver it safely and have the requisite, systems around them to keep people safe, to monitor their patients, particularly for HIV, which is lifelong treatment, right? You don't go off your drugs.
Sure.
It's a chronic disease. So, as we worked on first, you have to get the medications into the country at the prices that they can afford. So that's why I worked on procurement and pricing. Then you have to get the medications out of the hospitals and the fancy acute care centers, relatively fancy even for developing countries. And you got to get them down into the rural communities, into clinics. Often those clinics are not staffed by physicians, right? Most of them are not. There aren't enough physicians to go around. They're staffed by nurses or paramedical professionals, non-physician clinicians, as we used to call them. So the more you decentralize the supply chain and push the medications out to where they need to go, rightfully so, the more you have to think about, do I have the workforce to adequately deliver, monitor, follow up, diagnose, manage a whole range of HIV conditions and associated conditions. So that's what started this work. I was spending time in all of these rural clinics. I spent a year in Uganda prior to moving to Rwanda, simply driving around in a beat up old Camry to clinics and trying to help them do quality improvement, like measuring, do they have enough drugs? Are they monitoring their stocks? Are they prescribing correctly? It was really clinical operations and public health operations.
Yep.
But in the process of that, you realize something very clear is that people present to the clinic with a whole range of issues. And what we had done with HIV is we infused a lot of resources into these very weak health systems on the back of one disease, HIV, and maybe a few other related conditions, opportunistic infections, but that there's a host of other things that people were dealing with in their daily health and lives. High blood pressure, high cholesterol, heart disease, reproductive health issues, other infections, sexually transmitted or otherwise, so on and so forth. Basically, primary care, right? Anything and everything. And these clinics are not set up to deal with the vast majority of those conditions. So, what did we do? We took inspiration from a prior program called the Integrated Management of Childhood Illness, which is basically a simplified way of getting children vaccinated, screened for malnutrition, diagnosed for things like malaria, so on and so forth. The basic things that threaten childhood in developing countries from 0 to 2, and that that lead to increased infant mortality. So we said we can train relatively low skilled health workers, and they're fantastic, by the way, and community health workers. So I use that skill just in terms of the way of formal education. But we can train non-physicians, relatively lower skilled health professionals to do a whole range of things using something called syndromic management. So basically, rather than saying I have a blood test, which you probably don't have out in those clinics, I have a blood test to diagnose conditions X, Y, or Z. You say, well, I have this package of symptoms, this constellation of symptoms, and that likely, with this kind of sensitivity and specificity, that's likely to correlate with this kind of condition. So it's better that I treat it syndromically than let it go untreated. You can put that for malaria, kind of pneumonias, rashes. And so we said the same thing. As we started to decentralize HIV treatment, all these other conditions came out of the woodwork. People started actually coming to the clinics because they knew that the clinics had AIDS drugs and HIV drugs. And so then they started to reveal all these other problems. And we said, well, we better get the drugs for those, and we better get the tests for those. And we better train these health workers to do integrated management. So to do syndromic management of a range of conditions. So we kind of measured what are the most common things that people come to clinics for, and can we develop similar validated syndromic approaches to manage it? Essentially, it was a massive public health campaign to get health workers doing more than to upskill and to get health workers doing more on the back of HIV funding and support.
Hmm.
So my dissertation was all about in a health system like Rwanda, which was investing a lot of resources into the rural communities, which was, very controlled centrally, but very standardized. What does it look like to actually support nurses? And are they doing a good job? And are we supporting them adequately? And can we direct people to these clinics with some semblance of assurance that they're going to get good care and it's going to be safe care and it's going to be high quality care? And so that was the entire thesis was, can we do this? What does it look like in practice? And what are the results? And
Hmm.
I was really proud of that work because it was a lot of boots on the ground, a lot of time spent in these clinics, often without electricity and running water, but you got a committed nurse or a committed paramedical professional with a few drugs and a lot of sharpness, a lot of wit, a lot of guile, and a lot of information that some of it which we provided in terms of training and education, and then watch them do their work
Hmm.
and support them along the way. So yeah, we were really proud of that. And the good news is that that's now the basis. That protocol is now the basis for training
Right.
for primary healthcare workers in Rwanda
Yep.
and in many countries around sub-Saharan Africa, because not only the work that I did, but the work that others did to kind of support that training module.
Hmm. Hmm. And it's interesting as you're talking about that. And again, behind it is, as you were saying, we have, based on that early work, developed this very, if you look at HIV, this aggressive, disease-specific, concept of how we can reduce disease burden with this integrated approach. Take a couple minutes just to compare that because that was sort of disease agnostic. A couple of years later, at WHO, you publish a very interesting paper. It was entitled Beyond Hypertension, Integrated Cardiovascular Care as a Path to Comprehensive Primary Care. And in this case, major killer, small amount being, both in developed and non-developed countries being devoted to it still. But again, cardiovascular care, much more than hypertension, as we know, tobacco, exercise. There's a lot of things you looked at in this one, per the WHO CDC collaboration. What were some of the things you learned from working on global hearts?
Well, I don't ever want to pit diseases against each other.
Sure.
And because, for the patient, it's
Right.
their most important thing. And so I kind of begin and end there.
Yeah.
But there's an opportunity to build both in both directions. So vertical programs or what siloed vertical programs like that for HIV can teach us a lot about what's missing around it.
Yeah.
And then it requires that we do more integrated things. Hypertension is one of those things that's a silent killer. It requires really a lot of basic primary care, health education, dietary and lifestyle modification, but can also be managed through medications, as we all know, and getting people on evidence-based therapies. It's obviously linked to a lot of other things, right? It's linked to kidney problems, it's linked to high cholesterol, and then further down the stream, heart disease and stroke, right? Which are the
Sure.
principal risks of long-standing untreated hypertension. And so, um, we tried to take the same sort of principles of how does a focus on getting people on these very simple and evidence-based frontline therapies, how does
Mhm.
getting nurses and frontline practitioners to think of that as a part of their remit, to really focus in on their role in prevention and early intervention for hypertension as a ground laying principle for how we do other parts of basic primary care,
Mhm.
right? So you
Mhm.
can approach it from the integrated management perspective, or you can approach it from a disease or a group of disease perspective and kind of build out from that. I'm sort of agnostic on which you do, but one thing that is, one thing I've tried and I continue to try, even in my work in public health here, is to de-silo our work
Yeah.
and to get us working more collaboratively across teams, across subject matter experts. I mean, public health is vast in that regard. And we've got to but there are generalizable principles that are shared,
Mhm.
and that we have to get subject matter experts talking to each other, working collaboratively, not just designing in silos. And there's always a tension there, right? It's much easier to galvanize support and interest and resources for vertical diseases, right? Because you can captivate someone with the story of someone with HIV or the story of someone with hypertension or the story of someone with not even hypertension, heart disease. You can captivate them with these stories while also, it's much harder to get them organized around integrated management or the foundations of health systems or primary care. But on the ground, in the real world, one doesn't work without the other. So the
Right.
Hearts work that we did was very much brought that stuff to life, right? Which is you got this insidious killer, you've got some simple solutions that can be worked on at the front line of developing country health systems. What can we do to bridge that gap? What can we do to train up health workers to do more integrated management, but also to use routine blood pressure checks as a means to sort of a means into health education, a means into screening for diet and lifestyle and nutrition, things that are harder to catalyze a conversation around if you don't have objective data.
Mhm.
Often, whether it's syndromic management or something like the blood pressure screening that we tried to advance, you need an objective data point to catalyze a lot of subjective information that the patient will tell you. And that's been my experience as a primary care provider. One little data point, one elevated lab can trigger this whole conversation about how are you living?
Right.
What are your social circumstances? What are things like at home? Are you employed? What's interfering with your ability to manage your blood sugar, your blood pressure, your um, diabetes, your whatever it is? And so that's a big lesson from that work. And I think it's kind of the holy grail of building health systems in developing countries is as long as there are health worker shortages, you cannot specialize
Yeah.
at the front lines of systems. So you need these kind of pluripotent health workers that can do a lot of things. And we see this even in our own system, right?
Sure.
Generalism is a dying breed in um, American medicine, in part because of the way we pay for medicine, the way we
Right.
pay for healthcare in this country. But make no mistake, it's needed.
Oh
It's
yeah.
needed, and if anything else, if for nothing else, then as a solid gatekeeper to the rest of the system.
Absolutely. So you join New York City Department of Health and Mental Hygiene in 2016, and your team launches what's known as the NYC Health Justice Network, which is focused on promoting health and wellness of people re-entering the community from incarceration. It's funded with CDC as well as NYU and CUNY. Very interesting collaboration. And one of the things that you published as a result of this work is an interesting paper in 2019, a Journal of General Internal Medicine, Trauma-Informed Care, a strategy to improve primary healthcare engagement for persons with criminal justice system involvement. Talking about again, with the social determinants umbrella, this principle of recognizing the role that trauma plays in all aspects of health, physical health, emotional health, behavioral health. This is a fascinating body of work, and I'd like you to take a little time, just talk a little bit about sort of the genesis of it all from 2016, but a little bit of what you learned in this principle of trauma-informed care.
Well, this is kind of what I was suggesting was a bit of a question for me when Dr. Bassett was recruiting me to the health department. She said, "Look, I've got this team I want to build. I want to focus on this population that falls through the cracks."
Yep.
I didn't know that much about the issue other than what I had seen in my own patients, right? Where I was taking care of a number of people who were coming home from jail and prison with a lot of complex health issues, but I didn't know all the implications of Medicaid rules and access to care inside correctional health systems and the issues there. I wasn't well versed in this space, not only because it was domestic, but also because it just wasn't my focus. But she convinced me that a lot of the same issues of lack of access, of systems failures, lack of integration of care, policy failures as well, um, were driving gaps in care and differential outcomes for this population. In the first year after discharge from prison, people who have been incarcerated for any length of time, but particularly those who have been incarcerated for longer lengths of time, months to years, have a 4-to-1 increase ratio of death in the first
Mhm.
year.
Yep.
In the first month, 100-to-1. Most of that's driven by substance use. And most of them drop off of their Medicaid, which they're eligible for. And so we were looking at these gaps of care and we said, what are the principles that we can build? What are the programs we can build? What are the policies we can work on to ensure that they don't fall through the cracks? And I leaned a lot on my global health experience, community health workers, frontline healthcare practitioners, and integration of healthcare and social services. So the Health Justice Network was very much built on those principles. So how do we get two systems that don't really talk to each other to work in partnership? And by that, I mean frontline primary care systems, mostly federally qualified health centers, and criminal justice reentry organizations that basically do everything but healthcare, housing, social support, employment, um, everything, retraining, community work, right? So I created a consortium. We created a consortium that brought together three big primary care organizations and three big criminal justice reentry organizations with us as the architect
Mhm.
and the designer, and really built a workforce of community health workers, peers, people who themselves had lived experience, which again is a best practice from the work I've done on HIV and otherwise, peers, people with lived experience of the condition or the issues
Yep.
that or that come from the same community are the most credible messengers to keep people engaged in services and care. And we built a little system of care to take care of people exiting incarceration and to get them into an integrated package of services, to keep them out of the hospital, to keep them out of re-incarceration, and to find some semblance of stability at a extremely unstable time where their health is very unstable, but that's driven also by their social and economic circumstances.
Yep.
So a lot of the principles ended up being the same programmatically. Where I really grew was in the policy and political realm because I realized that, or we realized as a team that there was just a lot of reasons why a lot of bad policies driven by bad politics were the reasons why there were all these failures for this population. The reason why, your Medicaid turns off the moment you hit a correctional facility. The reason why there's delays in it turning back on, the lack of oversight of correctional health care, the employment restrictions that people have coming back into the community, the things that prevent them from getting jobs or getting housing, right? Because they have a criminal record. So we
Mhm.
worked on all of those fronts. But the common theme that throughout this and really piqued my interest was mental health and
Yep.
trauma. This was a big theme of this work because we were asking this very central question of why do people struggle to engage and stay engaged in care, whether that's healthcare or social care, and what's driving that lack of engagement? We said very clearly and found very clearly, both in focus groups and in surveys, that it came down to trust or lack of trust, institutional trust, especially trust in government, the same governments that had incarcerated them or punished them. So that's understandable, right? So, but that lack of trust also comes from trauma, both trauma experienced as a child and throughout the life course, but also more recent trauma, perhaps experienced inside jail, inside prison, and in the context of whatever got them there in the first place. So that became a common theme. And so we investigated if our sole goal was keeping people engaged and making whatever we built sticky so that people would keep coming back,
Right.
we had to adopt trauma-informed approaches. So we became kind of experts on it. What does it mean to be trauma-informed? What does it mean to show up in a particular way? Asking not what's wrong with you, but what's happened to you, right? What are the things that are driving where you are today? Not why you have hypertension, but what's driving that, right? It's really a lot of it ends up being like a root cause analysis. And we, of course, found that a lot of the clients we were serving had co-occurring mental health issues, whether they were serious mental health issues. A lot of them had serious mental health conditions, but even less serious. or less chronic, but all of them were impacting their engagement. So that's essentially what we built. We built a model that was about wrapping our arms around this extremely vulnerable population that, frankly, society has disregarded and stigmatized, and that we could potentially bring out from the shadows and reconnect them into systems so that they could stabilize their lives. We also felt, and I wasn't necessarily around long enough to see this happen, but um, we knew, and we still know today, and we're seeing a lot of this even with our asylum seeker work here in the city, that these principles are generalizable to other populations that have
Right.
also experienced a lot of trauma, refugees and asylum seekers, victims of domestic violence and interpersonal violence, and yes, people in the criminal justice system, amongst others. So there's a lot here, and I think it's a real untapped part of our healthcare system, which is essentially asking this very central question of why or why not do people show up?
Right.
People vote with their feet. And if they don't like what you're producing, which, I mean, frankly, most people don't like American healthcare in its current form, how can we adjust? How can we adapt? How can we actually bring care closer to where people are, but also do it in a different way? And so that's what we tried to solve for. And I'm glad that that program still persists today, and hopefully over time we can grow it even further.
Absolutely, and it's again, it's an example of some of the toughest of the tough, as you were saying, cases.
Yeah, I was trained under the adage, by Paul, but by others, do the hard things first
Mhm.
and go to the hardest places first. Because if you can do it in the hard places, if you can do the hard things, the rest of it should be easier. And it also becomes easier for you to convince others to get past their inertia.
Right. Right.
Paul was so compelling and Jim was so compelling because they would walk into these rooms in New York, in Geneva, and in Washington, and these places where big decisions were getting made about whether or not to do something for HIV. And they would say, well, we're doing it in the Central Plateau of Haiti, where there's no Wi-Fi, there's no running water, there's basically no arable land, and we have managed to do this. So what is holding you back? We're doing it with relatively modest resources. What is holding you back? What is the intransigence, the lack of political will? Where does that come from? And they held up a mirror to these sort of big institutions that were, for a time, sitting on their heels, or on their heels and not doing enough for HIV. So that's really stuck with me. How do you get these kind of big bureaucratic institutions moving? Because the power of government, and this is another Paul principle, government is the only institution or actor that can protect social and economic rights,
Right.
rights to healthcare, housing, schooling, nutrition, so on and so forth, right? Those are basic social and economic rights that only government can ensure. And so there's nowhere else I would want to work to try to do things at scale,
Right.
right? But for that, you need to move these institutions, which do have some baked in inertia. Every institution, not just health
Yeah.
institutions, but have this baked in kind of inertia and risk aversion and conservatism. You got to get them moving, and we only do big things as a society and as a country when we take it on ourselves to challenge that and to move it forward. As a city as well, we have a long history of doing that here in New York.
Absolutely. Yeah, definitely. So, great. No, I appreciate all this background. I think it builds up to why you're doing what you do now. So, end of 2021, you're serving senior public health advisor to the mayor. 2022, you become the commissioner of health. Um, say a couple words about the organization, if you will, because on a previous episode we profiled NYC Health and Hospitals and a little bit of sort of the pandemic preparedness stuff that they're up to. Obviously, you got a much broader purview. The vision and the strategic plan is a city where all New Yorkers can realize full health potential, regardless of who they are, how old they are, where they come from, what neighborhood they live in. Quite a bit, a $1.6 billion budget, 7,000 employees, 8 million New Yorkers is your purview. Say a few words about sort of the organization, a little bit about your day to day, and then we'll get into to a few of the current programs.
Yeah, well, let me just take the bridge. I think the one gap we didn't cover was really Fountain House
Sure. Okay. Sure.
and
Sure.
this bridge between the health department and my time as commissioner. And I had the privilege of starting to leading this organization called Fountain House, which
Yeah.
pioneered this clubhouse model, a model of social connection for people who were very social isolated, people with
Yeah.
chronic severe mental illness. And I only knew much about that from two things. One is the patient care. I've taken care of a lot of people with serious mental illness who have other physical health conditions. And two, from the work we just finished covering on criminal justice reentry, where there was a lot of intersection there. So when I visited Fountain House, when they were recruiting me, I said, what is this thing? What is this place? What is it all about? And what I saw in spades was basically partners in health in a building, in a co-located place. It was accompaniment, it was social justice, it was the do whatever it takes ethos to protect people. And what I also saw was a real opportunity for scale because through some grassroots activism and just time, there were over 200 of these clubhouses around the country, another 100 around the world, at varying degrees of quality and impact. But Fountain House was the originator. So I took, my goal there was to transform that organization from a local, small New York City institution to one that has national and international impact. And the pandemic hit right when I started, or just a few months after I started, and we not only went into bunker mode around protecting people and saving lives, but we had to um, transform the organization, which we did, you know, really unifying a network of clubhouses around the country, expanding to LA and building this national footprint, getting this work of clubhouses and psychosocial rehab into Washington and into appropriations bills. There's now even a clubhouse caucus led by
Hmm.
Congressman Torres and others. There's just a growing movement because this is like a solution that's been hiding in plain sight. And I have to say that, you're seeing this in cities across the country. SMI, serious mental illness, is a political hot button issue because people see it visibly on their streets and in their daily lives. And that's just like the iceberg phenomenon. You're seeing just the tip of the iceberg, but the rest of it's underneath the surface of the water. Well, yes, I mean it's essentially a much bigger problem. There are 14 million people living with SMI in the country. There are over almost 300,000 here in New York City. And so there's a real opportunity to start to build a community system of care, a community mental health system that John F. Kennedy wanted to build when he shut down the asylums, but never got the chance after his assassination. And no one since has really taken that up until the pandemic. Between the first relief bill that the president, former president signed to the more recent ARPA and bipartisan Safer Communities Act, we're seeing
Hmm.
billions of dollars go into mental health, into frontline mental health that we've just never seen before. And so why I'm telling you all this, because in the process of doing that, my work became more and more and more political and policy relevant.
Yeah.
And that's when I started to sort of serve as an advisor to campaigns and to at every level. And got to know a lot of the people running for mayor here. And so that was part of the reason I was appointed here because you're just present in people's
Sure.
dialogue about how to solve these big pressing public health and public policy issues. So a little bit about the department. I mean, this is the best public health department in the country. We have, as you said, like a $2 billion budget, 7,000 employees, a 200-year history um, of work. We're the oldest and the largest public health department in the country. We're larger than many state public health
Sure.
entities.
Yeah.
We actually have more spending per capita on public health than any other jurisdiction in the country. And the only other public health agency that's bigger is the CDC.
Yeah.
And so, my predecessors have gone on to lead the FDA and to lead the CDC and
Sure.
to make a bigger impact around the country. And so, it's such an honor to be in this role. It's such a storied role. And we obviously were the epicenter of COVID for the better part of 3 years. And um, much of what we did there served as the basis for what the country did because we had to deal with it first. So, and that just is what it is. New York City is, as I've written more recently, the canary in the coal mine for public health challenges, whether it's chronic issues or or acute infectious threats. And so it behooves us to kind of really focus on cities, but New York City in particular, from a domestic context,
Sure.
as a harbinger for what's to come. So it's an incredible place. Public health writ large is an extraordinarily diverse set of work. We do everything from frontline clinical care, disease surveillance, public health communications. We supervise the New York City Health Code and the Board of Health, which actually is a body of law under the control of the commissioner and the agency. We have incredible authority for mental health and local mental health. We're one of the few health departments that actually has integrated mental health and physical health.
Hmm.
We issue tons of regulations and rules that make the city safer and healthier, like our tobacco control work, our lead screening. We do a lot of environmental health work, in addition to our just routine disease surveillance and communicable disease efforts. We have been pioneers in health equity at this agency, really defining, particularly under Dr. Bassett, a place-based approach, understanding that these really clear racial inequities in health outcomes are very much place-based because of the long history of segregation and concentrated poverty that was created by things like redlining and
Sure.
structural racism that we're starting to unpack and reckon with as a society. So our remit is large. You mentioned New York City Health and Hospitals. They're a wonderful public safety net hospital system. They're about one of 11 big health systems in the city. They take care of 1 million, they have 1 million patient visits a year.
Yep.
But there are many, many other health systems we have to work with
Sure.
in order to do anything at scale in the city of New York. And that's a lot of our role is in being the final health authority for the city to see the whole field at a place, the entire city is my patient, 8.5 million people, which means that you got to really understand how things cut across neighborhoods, cut across institutions, and we can't get too caught up in these kind of institutional or parochial challenges that any one group faces. We've got to really think about cross-cutting issues. But our focus very much in the kind of post-pandemic era has been on transformation and evolution. We've set out a very clear direction, and a lot of that is about being the city's health strategist and marshaling the resources that we all share because we know at the end of the day, health is a team sport.
Yep. Absolutely. Let's drill down on just a couple of these public health challenges because you're doing quite a bit. And I thought an interesting place to start would be, especially in talking about Fountain Health and the clubhouses and severe mental illness, would be a recent piece in JAMA as a Viewpoint article you wrote back in December 2023, a public health approach to New York's mental health crisis, and specifically in this Viewpoint, you drill down on the opioid crisis, which I'm down the road 90 miles from you in Philly, and we got our own problem here at the sort of heroin, fentanyl, xylazine epicenter of everything happening there. You've made some interesting inroads in terms of these harm reduction hubs, and love to hear a little bit about again, what you're doing and a little bit of sort of the public health approach to this severely unmet because of a public health need.
Yeah, I think what's been sorely lacking in mental health writ large, not just in New York, is the sense that public health brings its tools to bear on the issue, which means number one, that you've got sort of central planning and that you're designing around some central population health goals. For overdose, it's reducing our overdose by our goal, reducing our overdose deaths by 25% by 2030. For serious mental illness, it's about reducing the number of people who are with SMI who are disconnected from care by half. by 2030. And so on and so forth. For youth mental health, it's about ensuring that we're reducing the numbers of children and teens in particular facing depression, anxiety, hopelessness, and so forth, which is why we've taken on some of those challenges. That's what it means. And it means also focusing on prevention, not just on care. When you have a kind of underinvested in, starved system like mental health has been in the country for decades, the focus tends to be on, can I get a doctor or a provider when I need one? And that is not a trivial thing, but it's not the only thing. And this gets back to these issues of trauma and social determinants. Are we addressing the upstream factors that are worsening mental health in the first place? Are we addressing social and economic drivers? Are we addressing things like employment and income stability? Are we addressing things like nutrition and physical health issues that we know have an interplay with one's mental health? I think these are all key questions that have gotten less attention. And so that's what we've laid out in our mental health plan, which is called Care, Community, and Action, which outlines three core pillars of serious mental illness, overdoses, and youth mental health. And so the JAMA paper you're referring to just takes one of those pillars as a lesson or as a use case for how
Yeah.
we've thought about this. But I think it's a good framework and it's a good starting point for a lot of the activity you're seeing, whether it's our dramatic investment in clubhouses, our expansion of digital mental health resources for teens in New York City teen space to open up a front door to the system, which can be too hard to find, whether it's our focus on social media and the work that we've done there, or whether it's a focus on, as you say, safe consumption facilities and overdose prevention centers, but also our work to expand naloxone and treatment access. So having a public health approach allows us to kind of take that wider frame and invest upstream, but also invest downstream in acute care and understand that it is a virtuous cycle if we take a comprehensive approach, which has been sorely lacking, I think, in mental health, as opposed to there are other areas of success, right? You look at cancer care, you look at other parts of our public health apparatus, we do take comprehensive approaches, or at least more of them than mental health. Somehow we've just been so focused on care and treatment and because in part because we don't want to talk about it. We don't want
Yeah.
to talk about it until it's a real problem that you can see. And that we know that there's so many missed opportunities for early intervention, early diagnosis and treatment. If you get someone, just take SMI, for example, if you get someone with schizophrenia or bipolar disorder or major depression, if you get them treated in and around their first episode in their 20s, late teens into their 20s, they can have a very similar outcome as someone without that disease in terms of social, economic, and health outcomes.
Sure.
But if you let them proceed undertreated or untreated for decades, then you end up with people who are, frankly, many of them functionally disabled and permanently so. So that is crying out for a public health approach. So that's
Absolutely.
why we wrote that paper, but that's why we've really launched our efforts here in the city.
Um, January 2024, American Journal of Public Health. Public health should lead the charge in improving life expectancy. Again, you're pointing out here, obviously coming out of a pandemic and other issues, our life expectancy in this country, unfortunately, has dipped a bit. You set a goal in this paper of boosting things from 2020, where we were at 78 years life expectancy up to 83 by 2030. Again, looking at this broadly in terms of not just chronic degenerative diseases, but overdose, suicide, violence, maternal mortality, and then also, you mentioned social isolation before. I know there's been a lot going on in New York at the state level with the late Dr. Ruth Westheimer being the loneliness ambassador. Obviously, at the federal level with Surgeon General Murthy talking about this epidemic of loneliness that we have in this country. Say a couple words about what's happening and what your plan is for life expectancy, because this is a health span. This whole concept is an extremely hot topic for us in recent years. I'd love to hear your
Yeah,
perspective on it
yeah.
from a public health angle.
It's very simple as far as I'm concerned. When during COVID, we did two things well. One is that we all kind of understood what the assignment was. And two, that we marshaled every sector behind that assignment because we had a common enemy, a common challenge, public, private, nonprofit, philanthropic sectors all working together. Because as I said, health is a team sport. So I asked myself, and we asked ourselves here at the health department and in the city, what's our next challenge in this non-pandemic or post-pandemic era? What is the central thing we can organize around that we can get everyone behind? And it isn't just one disease,
Right.
but it is the summation of our health.
Right.
How long we live and how well we live are very much harbingers of our health. And as you said rightfully, American life expectancy has fallen. New York City experienced the steepest drop in life expectancy in 2020, largely due to COVID. But when you unpack the data, you see that it's other causes like overdoses, like chronic diseases, like mental health, suicides, violence, overdoses that are driving this as well. And so it's not inevitable that we're just going to get back to where we were when as COVID wanes. And frankly, where we were isn't all a great story. In the decade prior to COVID, American life expectancy flatlined for the first time and actually experienced a dip for the first time in a 3-year period prior to COVID, then the first time since the 1920 flu pandemic. So after 100 years of progressive growth, largely on the back of public health and prevention, right? Better sanitation, antibiotics, better surgery, anesthesia, HIV drugs. I mean, name it, tobacco control, all of it. So we defined life expectancy as a common health challenge around which we could marshal our entire city. And you'll see back there is a sign for Healthy NYC. That's our initiative. That's our signature strategic initiative. It is indeed our strategic plan in many ways to address these leading causes of premature death, of citywide risk, of excess death, building on the traditions of public health in each of those domains and really putting quantitative goals out there that we have to aspire to, like 3x5, like everything that I've worked on in my career has been goal oriented. And even if we didn't reach the goals, we made measurable progress. And so that's what we're doing as a city. And it's really serving as a galvanizing North Star for our agency, for other city agencies, for the private sector who is like just waiting for marching orders in health, for philanthropy, and for our nonprofit community organizations as well. So we'll be hitting our year anniversary, but we've done a lot underneath that. Healthy NYC is organized into 3 main pillars. One is a very loud and proud public campaign and a effort to sign on as many key organizations as possible behind the effort. It's also an effort to get everyday New Yorkers engaged in this notion of health span, lifespan. Number 2 is this series of learning collaboratives we're launching soon that are very much organized around the programmatic work and the policy work, cross-sector work, driven by a learning collaborative and quality improvement approach. So we're actually tracking outcomes and tracking progress towards those quantitative goals. Because if you look at underneath it, if we achieve the highest ever life expectancy here in New York by 2030, we will have saved over 7,000 preventable deaths,
Yeah.
averted over 7,000 preventable deaths. That's 7,000 New Yorkers that we can actually interrupt their trajectory. And then the third pillar is on the economic side. So bringing back to my economic roots, we have a fundamental value proposition problem. We keep spending on the wrong things and expecting different outcomes. So how do we start to shift the gradient of spending away from high cost acute care and lower yield acute care towards prevention, towards community work, towards upstream work, towards early intervention? And so on all 3 of those fronts, we are making huge effort, and it will serve as our North Star for years to come, not only because it's sound, but also because we then passed a local law recently to codify it into our planning. So every 5 years we have to update it.
Yeah.
So I think we've done a really wonderful job. My team has done an incredible job at laying out a health framework for the city for the first time, a population health framework, really for the first time that doesn't talk about just one disease,
Right.
but that really says what are the drivers of better health and longer lives.
Yeah, no, it's extremely refreshing, especially when you think of the connection of all, the sort of the trillions that we spend on a lot of these chronic degenerative diseases. If you have some final messages or anything coming up that we should know about for the rest of 24, please let us hear.
Well, there's a lot happening. Ultimately, at the end of the day, what happens in New York City is a harbinger for the rest of the country. And that means also as public health as innovators, as we work to redefine public health, not just as a set of institutions, but as a set of bridges and connections between healthcare and public health, between communities and government, between the private and public sectors. As we start to really build out this framework for health as a team sport, a lot of the infrastructure we're building here, whether it's Healthy NYC, our work in mental health, stuff that we didn't talk about, our data infrastructure, our workforce resilience and wellness that we're investing in, all of those things will lead us to be better prepared for the next health emergency if it comes, but also better prepared to address our chronic health challenges and health inequities that plague us every day and that put us at greater risk for those things to play out during a pandemic or the next health challenge. So all of this is in service of bringing public health into the 21st century and really making it ready for whatever comes our way. And I think our team here in New York is doing just an excellent job of building that future here. So I'm very proud of them and proud of us.
Awesome. Awesome. Well, I wish you and your team the best with all of this as you move forward on this all important mission. And we'll have to do a follow up because a lot of other topics to get into, but really
Yeah,
great having you, Dr. Vasan. And it was a wonderful discussion.
real pleasure. Thank you, Ira. I appreciate you inviting me. Thank you.